is usually transit back. All right. I put this here because it's so characteristic. I want you all to see it and you develop the pattern recognition. So cock walking, right? This is quite a characteristic feature, strutting on the toe and leaning forward and facing it. Why you still see the upper limbs involvement, but the shoulder abduction. And when you see this, immediately thought about the
ครับเมื่อเดินไปเดินมาจะพบว่ายิ่งเดินก็ยิ่งเร็วแล้วก็ปล่อยเท้าถี่ขึ้นจนกระทั่งทรงตัวอยู่ไม่ได้แล้วก็ล้มลง
immediately thought about the manganese intoxication, right? And these are the manifestations of all these, manganese intoxication. They have Parkinson's disease, they have this type of gait, and they also have manganese madness.
มีลักษณะเฉพาะ
But the cock walk gait is not pathognomonic of the manganese intoxication anymore. What other disorder can have this kind of cock walk gait?
ผู้ป่วยรายนี้ก็จะเป็นผู้ป่วยที่เราสามารถได้ติดตามความเปลี่ยนแปลงในระยะต่อมา
What other disorder can present with a cock walk gait? For example, is Macado's Joseph disease. It has been reported to have this kind of cock walk gait as well. Right. Okay, and next part is oculomotor feature in terms of the red flag. And I think that we tend to overlook that patients with Parkinson's disease, they don't have eye movement abnormalities. They do. Okay, but we tend to overlook because we focus on the PSP phenotype, eye movement phenotype. I summarize here. A review looking on the different type of eye movement abnormalities in Parkinson's. But you appreciate here that none of them is really specific. It's not like you see certain eye movement and you say that this is Parkinson's. No, but they are not normal. Just want you to be aware with that. But we focus here on the eye movement of those PSP phenotype. And this is a study that's unknown in eye review. And it's actually the evolution of the eye movement in patients with PSP. Okay, the earliest abnormality, you can see that the earliest is not a single eye movement, it's a combination. Actually, square vector is one thing that I want you all to spot it because it's very easy once you recognize that the macro square vector. The slow saccades, can share you a bit of the videos how to explain for the slow saccade. But the presence of this square vector is really tells us there is something wrong with the midbrain that control the and the points that control the fixation. Okay, and you don't forget to look on the eyelids as well, the blepharospasm and so on. That is very common in those patients with PSP. Now, the macro square vector you can spot from the distance, like for example this patient. Okay, so you talk to them, getting the history, you can spot this kind of macro square vector. Okay, from the distance, and is considered as one of the core feature of the oculomotor dysfunction in the PSP criteria. So you need to be aware of it. Okay, what it means by the macro square vector, put the definition there. Okay, it's more than 5 degrees horizontal. Okay, and this is how you see it, and it's very visual. You can observe it. And how do you mean that it's, if the saccades of the patient is slow or not? It's very easy. If you can follow patient's eye movement, it means they're slow. If you ask them to do saccades, and then you are able to follow it, it means they're slow. Presumably, the saccades is normal. Okay? Like for example, this patient, you ask them to do saccades, and you're able to follow them. It's not normal, it's slow. Okay? And as you can appreciate here, the impairment, the vertical trajectory is affected in patients with PSP. However, at the initial stage, is slow, and the trajectory is actually curved, is oblique. And that is because the vertical is preferentially affected than the horizontal before the optimal paresis ensues at the end, the trajectory is become oblique. So that's why it has been named as Brown-House's sign. This is one of the frequent features you observe, but it's not early. It's not early. It's a mistake to PSP. And it has been described, another feature is called zigzag. So this is a zigzag eye movement. So it just tells you that the vertical trajectory is not very straight in patient with PSP. All right, I think we all, this is nicely demonstrated now. And the at end, you know that vertical supranuclear gaze palsy ensues when the disease becomes mid-stage or advanced. And what you ought to appreciate here that the Richardson's phenotype is actually affected down gaze first. And this is a study to be conducted quite a while back, and it's very well demonstrated that the Richardson phenotype of the PSP, which comprises only 20%, they actually have the down gaze first. With the scar. Can appreciate it, the patient can look down. All right? Okay. Now this is a study that we did quite a while back, which just demonstrates that the vertical is preferentially affected compared to the horizontal. And in the old days, what we did that we need to put the coil onto the patient sclera. So it was actually quite a technique that you need to put the coil on the sclera of the patient to monitor the eye movement, but it is very, very accurate. At the end, what is I think I put these studies here because at the end, I want you to all recognize that you don't rely on one red flag to diagnose any type of disorder. It has to be a combination. And this is very nicely demonstrated that in terms of the eye movement, you don't rely on just vertical supranuclear gaze palsy. It's a combination of square wave jerk and the slow vertical saccades and so on. And once you see the more feature that you observe, the accuracy actually increases. So don't rely on just one single feature. And this is study that they put it into the evidence that showed it to us. Now, the issue with the MSA, you know that is abnormal, there are different type of abnormal eye movement in the MSA. So just want to demonstrate to you here that the feature that's quite characteristic in patients with MSA is actually relies on the pursued eye movement. So you focus on the pursued eye movement, and you can appreciate here that is the pursuit is actually gone. It's all the microsaccades. It's all the subclinic catch-up saccades when you ask patients to do the pursued eye movement. It is one of the features that I want you to see. The other feature that I have not seen in my clinical practice actually is a head shaking nystagmus. But to do it properly, you need to ask patients to wear the goggles. So this is a way to do it. So you shake the patient's head horizontally for around 10 seconds, and then ask patient to look down, and then you observe this downbeat nystagmus. It has been observed to be very, very suggestive of MSA, particularly the cerebral phenotype. But I think that is not that very common. The other eye exam that I want to put in as the highlighted here is a patient with the corticobasal syndrome. I think I want you to listen to this video because it comes with the instruction that I don't need to tell you how to conduct this lesson.
Right. Are you doing it?
I'm trying to.
Okay. I would like you to move to the left, all the way to the left. Okay. Try to move all the way up, all the way up.
visually guided is okay in this type of patient. Okay, so this is one set of features I want to demonstrate here. With the verbal instruction, patient is dyspraxic, cannot do it. With visually
The
guided
pen.
is okay.
The finger,
And velocity in this type of patient is
finger.
normal.
the finger, the pen,
See, visually
finger.
guided is okay.
the pen.
The other thing that we might overlook in the clinical practice is that when we ask patients to do eye movement, we don't observe them long enough in patients with a have a delayed latency for the eye movement. You don't see them move the eyes and oh, it's palsy. Okay, so we need to wait a bit, many seconds. And some patients like this, I do appreciate here, they have delayed latency. It takes time for them to initiate the eye movement. Make sure that you spend time to observe that. And this is at the end that I put it as an example that the clinical feature is actually has been observed by the expert and getting the evidence, and many of them has been incorporated in the diagnostic. I think I mentioned about this in the first slide. And this is in your handouts actually in the PDF that you get from the link. I summarize all these red flags between different forms of individuals. So I think that's it for the eye movement. Oh yes, and I put it at the end. So I thought that what is going to be the quickie for the examination? So it's not comprehensive, of course, but this is a quick. So I put in as a what would be a pocket website checklist for the Parkinsonian syndrome? So I put it. You need to establish the core trio of Parkinsonism. You need to recognize the certain red flags that we put it, and I put a mnemonic there. Ask patients about the progression is one thing. Eye and facial clues are quite good when you do the quick examination. Don't forget to ask the nurse to check for the orthostasis, and this is a quick information that you get from the patient as well. And don't forget to exclude articles. And the next lecture is a drug induced, so I'm going to talk a bit about the drug induced Parkinsonism too. All right, I think that's it. That's check.